So my discussion is going to be a very short, and I will try to finish up within even 10 minutes. I'm not already the program is going time. So we all know what is obstructive sleep apnea. It is a metabolic syndrome. It is a common disease, as we saw in the morning. It is common disease of both adult and pediatric age group with myriad of presentation. It is a spectrum of disorder. It could be just primary snoring, or it could be severe OSAS. So the tailored approach is the key. So for that, proper workup is another key to be the success. So the first step is to identify the type of OSAS by clinical examination, the component of static and dynamic obstruction, with clinical examination or OPD evaluations like diagnostic nasal endoscopy or video laryngoscopy, or just a flexible laryngopharyngoscopy. The next step is to identify the severity of OSAS by doing a polysomnography. Any type of sleep study will tell you how severe the patient is having. That's depending upon the AHI, saturation level, etc. And the next important thing is to know the identifying the level of obstruction when you are planning for any surgical intervention. So like whether the obstruction is in the nasopharynx, velopharynx, oropharynx, or in the hypopharynx. But the most important step of tailoring which surgery will make this patient better depends upon identifying the pattern of obstruction. So the tailored surgical technique, the old traditional techniques are like uvulopalatoplasty, uvulopalatal flap, palatal and tongue-based channeling, etc., etc. But their limitations were non-selective with variable outcomes. It can range from 20-30% to 60-70%. Mainly because at that time, when the surgical management was introduced, these diagnostic modalities were not there, like drug-induced sleep endoscopy and dynamic MRI. So they wholeheartedly believed on certain procedures like Muller's maneuver, and they thought that the main obstruction is in the palate, that is the single level obstruction. So based on that, the original or the older Stanford protocol was identifying the level of obstruction, whether it is retropalatal, retroglossal, or purely retroglossal, or retroglossal and retropalatal. So depending upon that, they have suggested phase 1, phase 2 surgery, and the phase 1 was UPPP for a pure oropharyngeal obstruction, and for retropalatal and retrolingual obstruction, they have suggested UPPP along with genioglottal advancement and hyoid myotomy, that is a skeletal procedure. And in pure retroglossal, they have suggested geniohyoid advancement. So if this treatment fails in that particular patient, then they suggest phase 2 procedure, that is maxillomandibular osteotomy, maxillomandibular advancement. So that was the older concept. The revised Stanford protocol, we can bypass the entire phase 1 surgery and we can directly go to maxillomandibular advancement if you feel the patient will not benefit out of phase 1 surgery or soft tissue surgery. So there, and also they have included so many other surgical procedures, septal surgeries, nasal valve surgery, dynamic surgeries, and tongue-based reduction, hypoglossal nerve stimulator, myofunctional therapies, everything they have put together and revised this Stanford protocol. Identifying the multi-level collapse of upper airway is most important, and almost it is common in 90% of our patients. So only the remaining 10% may have only retropalatal collapse or retrolingual collapse. So there can be a combination of velopharynx and oropharynx or hypopharynx, or combination of nasal static obstruction with upper airway dynamic obstruction. So more the static obstruction, the surgical outcome will be good. So that can be identified by the phenotyping of the upper airway that has been discussed in the morning, I believe. So we have to identify the single and multi-level obstruction, and for which the DISE or dynamic MRI will be more helpful. Multi-level surgery can be done as a single stage or a multi-stage management, and more commonly now we are moving towards single stage procedure than multiple stage procedure. All depends upon the surgical expertise you have and the hospital team and ICU care and how you can manage the postoperative complication. It all depends upon that. Single stage multi-level surgery has been shown to be safe and effective. Various people here must be doing it, and the patient selection is also important. At the same time, that surgical team is also crucial. As I told you, the better assessment will be the better surgery, so can be the better outcome. So DISE and cone beam CT or dynamic MRI helps you to plan what surgical procedure that patient needs. So depending upon the type of collapse in the palate, for example, if it is going to be a circumferential collapse, the surgical options are you have to expand the velopharynx in all three-dimensionally. If there is anteroposterior collapse, you have to pull the palate more anteriorly. If the collapse is going to be more lateral, you have to pull the palate laterally, like expansion sphincter pharyngoplasty. Barbed reposition pharyngoplasty, more pull towards laterally, but that can also be tailor-made. Today morning, Dr. Srinivas Krishna was taking extra bite, because the mouth opening was narrow and the pterygomandibular raphe was shorter, and he took extra couple of bites to pull it laterally. So those kind of modifications you have to be prepared. Unless you understand the anatomy and pathophysiology and concentrate on your DISE finding, how it is happening, you can't completely elevate the problem. This is Professor Antony sir was showing zeta falta pharyngoplasty. I know. So I'm not going to show the entire surgery after tonsillectomy. Where is the mouse? Okay. This is an unedited video. I will just fast forward it. So we are removing that supratonsillar area, pad of fat, and going down to the level of muscles. Splitting the uvula in the midline. Usually this will be just approximated and sutured, but when you think in the DISE, you need more of lateral pull, and when there is the component of lateral collapse is much more than anteroposterior collapse, you can take a bite from the posterior pillar towards the pterygomandibular raphe to get a better lateral pull. So I am using a 2-0 vicryl and going more towards laterally, like expansion sphincter pharyngoplasty. So these are all small modifications which you can do to get a better lateral pull. So this bite where I am taking here, this is also important where you have to take. All depends upon your DISE finding. So if you think this lateral collapse is more superiorly, more towards the nasopharynx, this bite may not be sufficient there. You may have to take a bite little more superiorly. So all those has to be assessed when you are doing the procedure, when you are doing the DISE, and you have to re-look at the DISE just before surgery to understand much more better, and you can pre-plan where and how you want to do. So again, I am going through the same exit point and going towards that area and making a tight knot. When you look under the microscope, you will be able to appreciate that the posterior pillar has been pulled anteriorly and more laterally, and sometimes we may have to trim off this excessive tissue there. These are all modifications which you will be doing it when you are doing it more and more. So tongue base and hypopharyngeal procedure also same, how much deeper you want to go, how much of lymphoid tissue, how much of muscular tissue you want to remove, all depends upon your finding which you see preoperatively. Similarly, maxillomandibular advancement, this also has to be tailor-made. It is not just 1 mm, 5 mm cuts for all the patients. So how much you have to rotate all depends upon that particular patient, and sometimes even they will remove extra teeth on both sides to have a better advancement and a better approximation of mouth closure. And last but not the least is the nerve-based hypoglossal nerve stimulators, which are not introduced in India, but it has come to Asia. Soon I am sure it will come to India. So the tailored approach, the matching the surgery to the site or pattern of obstruction is key. Use dyes and imaging and sleep phenotype to choose what surgery will be better for that patient, and I am sure everyone will agree that one size fits all is absolute. And from ablative, we are moving towards reconstructive to tailored surgery. Imaging and endoscopy are the key, and the future is precision sleep surgery. Thank you.
First of all, I should thank our professor, Dr. Anthony sir, for his wonderful lecture he has given to us. He has always been a mentor for many. Thank you for that, sir. And Vijay, he is always a silent storm on the stage and silent behind. We are proud of you, Vijay, and he is a great friend of mine.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, sir.